Good morning, everyone. So today I am going to talk about the sepsis pathogenesis. I think the roster has given that the sepsis part 1 and part 2. So this is part 1, sepsis pathogenesis. Sepsis actually word started from the Hippocrates, in fact. And in that time also they have given that anything was a rodent, that sepnoids and that term. But then finally from the 1992 to 2023 till now, the definitions have covered the sepsis and the SARS. Earlier from 1992 it was that bacteremia, fungus, parasite, virus, and it caused the SARS and the sepsis. And the SARS parameters were the trauma, burns, and pancreatitis only. However, in now till 2023, it has altered with the sepsis and the septic shock. And this was also given that the SOFA scores, and it is also considered the mental status and the respiratory rate and even the low blood pressure. My outline in sepsis pathogenesis, role of intestinal immunity. I will start from beginning. Intestinal permeability, gut-liver axis, bile acids, which also comes under gut-liver axis, and integrated events. Sepsis is not alone. It's a complement activation, coagulopathy, autophagy, lipid disbalance. So sepsis pathogenesis is interconnected cascade of events in sepsis. How it starts? I will just give the little brief of the healthy gut, which everybody knows, only the students for the students. These are the Paneth cells, which secretes the antimicrobial peptide defensins, and even it secretes the TNF-alpha and phospholipases. Enteroendocrine cells, which secretes the glucagon-like peptides. Goblet cells, they secrete the mucin and they develop the Tregs. And the M cells, they prevent the inflammation. This intestinal villus is present only in the small intestine, cecum and jejunum. In the large intestine, in the colon, all these cells are not very popular. Only the goblet cells are the popular, which creates the mucin, thick layer of mucin and the Tregs. And that's the reason there is a difference of the microbiome from the small intestine to even the colon. So the healthy gut really modulates the immunity. It secretes the antimicrobial peptides and it controls the intestinal immunity controlled by the controlled Tregs and the homeostasis. In gut, how it starts? In general also, even in healthy gut, we face every day the lot of the bacteria. So what happens, this is the microbiome and, So this microbiome, LPS, which is the E. coli negative wall, LPS bind with the host cell with the intestinal HMGB1. HMGB1 is produced by the liver with the spleen, but the intestinal HMGB1 helps bind to the LPS to the host cell membrane. It facilitates the binding and it facilitates the endocytosis also in this. I think I should use this. So when it is endocytosis, the LPS, it activates the procaspase 4 and 5. Even in the healthy gut also, it activates the 4, 5, 11 caspase, which activates the gasdermin D, which cleaves now it makes the pore in the membrane, because gasdermin C is removed, but gasdermin D, MDN, it makes the pore, and then it makes a pore in the cellular wall, and the pyroptosis started. With the pyroptosis, the pro-IL-1 beta and pro-IL-18 converts into the IL-1 beta and IL-18. This is a healthy gut. Now, but with the continuous inflammation or with the continuous pro-IL-1 beta and IL-18 and other interleukins, what happened in the beginning of sepsis, all the tight junctions, which is considered or characterized by the occludin, claudin, and the jams, they are not tight. Now they are loosened up with the help of the myelin like phosphatase, MLCK phosphorylation happen, and this MLCK activation, what it does, it activates the paracellular pathways, which loosen up the now tight junctions. With the loosening of the tight junctions, translocation of bacteria and the toxin from the intestinal lumen to the liver and even the mesenteric lymph node. In the healthy gut, we know there are tight junctions. Diversity of the beneficial gut microbiota, which really have the lactobacillus, bacillus, clostridium, bacteroids, and the bifidobacterium. And all these bacteria have which start secreting the intestinal start secreting the IgA, and these all microbes bind as an antigen, and then the bacteria are and the detrimental bacteria both are binding with the IgA, and it is not harming our healthy gut. However, when there is a compromised junction and the microbes are inside coming, it creates that the low diversity of the gut microbiota. In diversity also, and there is a low production of the crop diverse and less binding of the antigen specific IgA, which creates the resistance to the polymyxin. And then now, once the microbes, I'm talking about only the intestinal immunity, and as we know that the gut contains 70 to 80% of body, with the dysbiosis, bacteria through the loosened junctions, and microbiotides and plants also come into the and interact with the monocytes, macrophages, intestines, macrophages, T cell, and start producing the IL-6, NO, TNF, IL-17 from gamma. So now what happens is that from the tight junctions it become loosened. Now bacteria entering into intestine, but till we are only always talked about the monocytes. So beyond monocytes or the neutrophils and the T cells of the immunity, there are now literature which says that mast cells are not much in the body, in the organs, but whenever there is an inflammation, mast cells are developing. And how mast cells in the gut it works? Mast cells are activated, not even activated still. How? This is the mast cell. So mast cell, when the bacterial toxins, there is a lysis of the mast cell. When there is a degranulation, and mast cell degranulation happens, which creates the inflammation. If there is a intact mast cells, what it does, it produces the IL-4, and IL inhibit the macrophages, and macrophages are not there for the phagocytosis. So if the bacteria are there, it also produce the IL-1, IL-6 and TNF-alpha, which makes the granuloma formation. This way, mast cells helps in the sepsis progression. Of the sepsis or the SARS, mast cells are there? No. Mast cells are only coming up when there is little cytokine recruitment of the mast cells happening in the liver or in the intestine, in the organs, after the only starvation. Another cell of the gut, innate lymphoid cells, as last time also, that the lymphoid lineage produce the ILC1, 2 and the 3. They don't need receptors. So with any microbial PAMPs or the DAM, they are interacting and secreting kinds with this. So presence of the lymphoid tissues are and the homing receptors are needed, and homing receptors in the gut, they start developing with the inflammation. Happen when the ILC is in the gut, when there is a hyperinflammation. Normal gut bacteria only tell of the IL-7. However, when there is a abnormal gut microbiota, increase the IL-7 secretion. IL-7 start producing the ILC1 triggers, and which makes the interferon gamma. We know that interferon gamma is the response, decrease the bacterial clearance and leads to the organ damage. More of the organ. Everyone will question that inflammatory, and it may it gives the more of the organ damage. These are important in the gut. In fact, there are a paper in 2020 and 2019 where people ILCs have measured in the blood, and with the healthy and the control, they found the increased one. Then they have even did with the SOFA scores, and they found there was a significant difference with the SOFA, but less than 8 and the more than 8, there was not much difference, but it was increased. C2 for the tissue injury, as I talked about, that in the severe sepsis or in the sepsis, more is organ damage. So ILC1 with the ILC make the more of ILC2, which 33, which are immunosuppressive. We produce 4, 5, 6, 9, and 30, and make the tissue injury. So does the ILC microbiota? Of course, this slide does not do not have in the liver. I have the neural networks and the microbiota, but they have given some kind of a hint that ILCs directly interact with the gut microbiota. That the gut microbiota directly see the ILC, and then IL-2 and the IL-22, and when the gut microbiota is recognized by the macrophage there, and IL-1 beta stimulates the ILC. There is a close interaction of the ILCs with the gut, so which gives me the hope that yes, ILCs are more in immunity than any other cells. Is there interaction between the ILCs and the mast cells? Because we have talked about the ILC and the mast cells also. So there was also a description that ILC2, which produced the IL-33, IL-25, and which also interacts with the mast cell directly or the indirectly. So intestinal immunity is irresponsible for the So I have picked up this in picture where they have given that there are the only 10 to raise power 3 or 5 microbes in jejunum, and only in the colon and with the cecum there are the 10 to raise power 15 microbes, with the increase of the short acid and decrease of the vitamin A. Why I am talking about this? Just giving you the hint that they are talking about, maybe this is very small, but this is the small intestine and this is the large intestine, with the idea that they have also given that intestinal immunity is with the ILC1 and the ILC2. So all immunity is not characterized the monocytes, macrophages. Cells are making probably the better sepsis. So what happened with the gut dysbiosis? It creates the sepsis. Sepsis again make the vicious cycle, which makes it to the, because we have talked about the intestinal immunity, and there is a breach of tight junction. It goes to the gut, liver. But there was also the best lymphatic circulation. Through the lymphatic circulation, only the endotoxin to the liver, and we know very well, and we talked about that in liver, neutrophils and the cell activation, which cause the cytokine storm and which comes into the systemic circulation and it goes back. So again, it is a cycle. So from intestinal permeability, it is breached, it comes to the liver with the dams and the pans, it again gives the insult to the liver and starts creating the activation, infiltrated. So systemic inflammation hypothesis, which is rated in 2021 by the Richard Morio, they have also that the PAMPs and DAMPs give the NLRP3 inflammasomes, which cause again the procaspase and procaspase IL-1 beta. And how can I miss the bile acids in the anal flora and come? But I thought that it will cover the gut-liver axis because bile acids are produced in, it is coming to the intestine, colon especially, primary bile in the intestine only as the secondary bile acid, which is the deoxycholic acid and lithocholic acid, the gut microbes. Only the microbes change into the primary bile acid to the secondary bile. Deconjugation or the deoxycholic acid, it starts creating the SIRS and the sepsis. What happens? Primary bile acids, when it goes to the intestine, it activates again the FXR of the intestine and even TGR5. It produces the FGF15, which creates the intake and output and even the hepatic lipogenesis. So it is again circle. It is coming from here, it is reaching to the intestine, converting into the secondary bile acid, going back with the help of into the liver and creating the circuit of it. So in the lumen and in the liver gut axis, there are the immune cells, and with the intestinal flora, it is changing, and it creates in the SIRS decreased chain fatty acid due to the, because there is more cholic acid and lithocholic acids. And it was given in the one of the study, not liver sepsis, in the kidney sepsis, the lung sepsis, when people have used phase acetate, propionate and butyrate, they have seen that there is no translocation and mortality rate was improved. So I already told decade of events. We cannot complete the sepsis only with the immune cells and the cytokines. There is a, when they start or inflammation start, there is a complement activation in sepsis. In the immune cells, there is C4, C5. It doesn't do anything. Only the complement system receptors are more important in the immune cells. The complement, even so C4B, it influences for the protective immunity. It is a gut AMP, antimicrobial peptide secretion more, local Tregs more for the homeostasis, even though there is a little of the oxidative stress, but still it is a complement. However, in the immune cell, when there is inflammation, there is more of the receptor of the activation. What it happens with the receptor activation inside the immune cells, it goes out and start creating the inflammasomes NLRP3 and creates the IL-1 beta. IL-1 beta is again circle. It makes the more of the CD4 T cell to produce the interferon gamma, and as I already told you, interferon gamma more, it makes the tissue damage. So complement system is connected with the immunity. Why it is fair? But when there is an activation of complement system, it makes the tissue factor. So which is the activation of the coagulation. And in the SIRS and inflammation, already there is a coagulation there is no better fibrinolysis and there is fibrin generation. With the help of this tissue factor and with the help of the coagulopathy, there is more of the fibrin. Even people have shown that post-sepsis, people develop the liver fibrosis. So this concept actually it comes not touched. There was a 10 to 15 reviews where it was saying that the post-sepsis patients are having the liver fibrosis alone. It has the even the kidney fibrosis because of the coagulopathy. It generates the fibrins. So there is a integrant complement and autophagy. What happens when there is a CD4 and C3 when people have it? This is a mice. What happened? They have seen that the autophagy, which is the main marker ATG16L, is down-regulated because the apoptotic LRP3 and caspase-1 and IL-1 beta. Surge to sepsis. What happened in the complements? As I told you, C4B complement is very protective. However, in the beginning waits, and there is a autophagy marker which is increased, and that time cells need force and for the energy production, and these all three components make the cells for survival and the proliferation. However, when the surge to sepsis, when the inflammation is more and more is happening, there is all is down regulated with the A receptor more expression, which are sustained of the bacterial sepsis. Now, change in the lipid metabolism, inflammation, it leads to the perturbation of the cell signaling. There is no response for the inflammation and energy imbalance, which creates the defective lipid metabolism. Mediators are secreted. What are the lipid mediators? Increased chlorinated lipids. In fact, chlorinated lipids is becoming the marker of sepsis, one of this. And what happens when the neutrophils make the MPO and the ROS, they also produce the hypochlorous acid, which converts the lipid molecule into the 2-chlorofatty alcohol. Chlorinated lipids are increased. Even in the neutropenia, when their neutrophils are less, MPO and C5 so this chlorinated, even it is becoming the sepsis. But this is in the lipid biology during the inflammation and sepsis. Even the HDL were the associate. How? Because LPS generally binds. When how it binds? There is a ApoA HDL, it binds with the LPS. And then it starts the TLR signaling. However, in the sepsis, people that 30% of HDL become low. There is no ApoA1, and even HDL particle size also changes during the inflammation and sepsis, which inhibit monocytes and even the neutrophil migration. Lipophil, when the lipid biology changes the cannabinoids, which induce the sepsis. What happened in the inflammation? There are the AGA and the 2AG, which induce the eosinophil chemotaxis and makes the leukocyte adhesion. Although they have given these receptors as the potential target, but these are only in the late stages, not in the first stages. So, even with the severity, short and the medium change acyl carnitines with the 210, they were associated with the SOFA, hepatobiliary renal function, again more of the renal. We have not observed any liver because I didn't get any literature for health function. So they have observed that the non-survivors had the more of even two-fold changes, and even the non-survivor had the more and the survivors had the less. They have used the this alpha agonist, but PPR alpha agonist, because with the acyl carnitines, they have observed that the PPR alpha is also in the non-survivors. PPR alpha agonist, However, they have found that there was also more of toxicity. The phase 2 clinical trial. So sepsis is a immunological conundrum. It's not a simple thing. I will give you the picture. Leading to sepsis, it has the all K cells, monocytes, and I'm putting the MAST and ILC also there. There are low Ig levels in the intestine and even in the serum, which does not bind properly to the microbes and absorb it. Different neutrophil mediated immunity, immunosuppressive hypercytokinemia, pro-inflammatory cytokinemia, complement lipid biology I have added, low HDL. This all make that effective bacterial killing and persistence of the nets. What are the therapeutic? Only 3 slides further, because I didn't find any for the sepsis therapy. So there, as you have seen, that there was a change in the lipidome, decreased HDL. What the people have used the HDL, but within HDL, there is a mice study, and there is even mimetic ApoA1 also they have used. It improved the renal and the lung function, phase 1 and phase 2 clinical trials. Low dose heparin, as I told you that HMGB1, in the first slide, HMGB1 binds with the LPS, facilitate inside endocytosis and make the pores. What people have used, that they have used heparin. What heparin does, heparin in GB1 will bind to LPS, heparin will bind to the HMGB1, and those are consumed. And then there is no procaspase 11 or 1 to pro IL-1 IL-18. So they have shown that sepsis mediated mortality if you don't use, but if low dose, they have used, it decreased the mortality. Hepatology 2019, this is a study, but they have used one drug, granisterone, which I have learned that is the nausea and the vomiting for the patients who are undergoing chemotherapy. They have stopped, they have shown in the models and even in vitro, it's a hepatology paper, mice model, that it stopped the TNF alpha and IL-6 secretion, which gives the lower injury to the liver. So this is the sepsis pathogenesis concluded. Thank you, sir.